Wow, that was a great start. So many ideas were brought up, so many issues. I've taken a lot of notes, but I think what we're going to do at this point is to go into a couple of case studies. So I'm going to read through some case scenarios. I'll read through, let's say, 4 of them, and then we're going to spend the next half hour or so discussing those scenarios in depth. So, okay. Scenario 1, insulin administration where there's a mismatch between clinical workflow and billing. Has anybody ever experienced that? Okay, in this case, a patient needs insulin. Insulin was loaded into the automated dispensing cabinet for the patient. Pharmacy generates a barcode on a separate sheet of paper for nurses to scan when administering the medication. Why? Because if they scan the vial, it's usually for a multi-dose, and that would be fraud, since it's only a single dose that they're administering it. So upon scanning the paper barcode in this situation, a message was generated saying that the patient has no order for medication. The wrong barcode was generated on the paper sheet, so in this case, a nurse has no option but to override or scan the vial. So can't follow protocol, all right? So that's one situation. Lab results. Let's talk about validation problems. In this case, when a lab system transmits results to the EHR and there's a mismatch with the patient's social security number, for whatever reason, the patient validation fails and the lab results don't file at all, okay? So as a workaround, lab staff delete the social security number in the lab system, then they have to retransmit it, go through the process over again. This creates delay in getting information into the EHR, and it could be significant delay, depending upon the other distractions and what's coming up in care. Situation 3, blood administration, overrides again. So in this case, a patient needs a transfusion. There was a double check of the platelets performed according to protocol. But while scanning the bag of platelets in the blood administration flow sheet, the computer system did not show the right screen. And instead, there was an alert that said incorrect medication. So in this case, the only way to proceed to the transfusion flow sheet was to override with, quote, barcode unreadable, as instructed by the blood bank staff as they were able to match the platelet unit number in the note section. So in other words, an override to get the work done. And I'll do one more. Here's a newborn without a record. In this case, a 31-week gestation infant was born via C-section and needed emergent care. The infant needed x-rays, needed antibiotics. For some reason, the newborn nursery had previously admitted a patient, a couple hours earlier, using the record that was intended for the infant, for the newborn. And so the nursery was unable to generate a chart for that newborn. So what was the workaround? Using the mother's chart, because the order had to go somewhere. And the infant required surfactant, and in this case, where we got a report after 2 hours, the nursery still has no record for this infant who needed emergent care. Okay, so we are now going to have a discussion. And real events, real situations. I know everybody sitting here can probably add many more. But let me just even start out by asking sort of a really basic question. And I ask this because all these reports that we get come through our Partnership for Health IT Patient Safety or our patient safety organization, and we try to look at data across the board to find out, to try to aggregate and analyze data on workarounds. But nobody reports a safety event by calling it a workaround. I mean, that just doesn't come in through a safety reporting system. So we had to do a lot of work to sort of filter these out and ferret them out. But one question I've got, and it's related, is do people even recognize workarounds as such?
So I'll go ahead and start. And I'm not sure I'm going to exactly answer that question because something popped into my head as you were reading the scenarios that I felt like I needed to say. And that was when we have system problems. I mean, we know there's system problems. There's issues that happen all the time. The one thing that I know we emphasize again and again, and I'll make the point about a scenario with downtime, is that if there needs to be a workaround or the system is down, it should not delay care. But you would be amazed at how many people believe that I can't possibly continue to deliver care because of this workaround or this downtime. So I'm thinking about the blood administration one. You know, there's no reason that you should stop care to the patient. I have an example in one of the previous places that I worked that the system went down, and there was a patient there, a pediatric patient waiting to get blood drawn in the oncology clinic, and they said, well, the system's down, so we couldn't draw the blood. And they waited for 8 hours, and they were so angry with us informatics, IT people, it was unbelievable. So I think that one of the things that we have to pay attention to as we go forward is that the workaround should not preclude us from delivering good patient care, whether the system is up or down. Okay, now, your question. Do people realize? I should be quiet. You guys go ahead. Come back to me.
I think they do. I think I can tell you heroic stories of people, you know, receiving superlatives for finding the workaround that gets the job done, because they're trying to deliver care. They feel like they're being thwarted in one way or another, and the person who discovers the workaround is celebrated for doing that. What we fail to do, I think, is to recognize it as such, as organizationally, and benefit from that, and learn and adapt the system accordingly.
You know, it's interesting. What I'm hearing so far is there's a view of workarounds as a gem and as a treasure. But I think many still look at them as, this is deviant behavior, right? You're not following the rules. And so for that reason, are people even afraid to say that they engaged in a workaround because they didn't follow the rules?
Yeah, maybe. I mean, my general sense of this is what's celebrated is the goal-directedness of the task performer. I'm going to get the job done, darn it, and I'm going to climb valleys and go through fire just to get the darn job done. Now, it might be the EHR is in the way. It might be the patient didn't bring X, that's in the way. I didn't get the referral auth, the transport's not here, where's the there's all kinds of stuff, particularly in very complex settings such as hospitals and physician practices. But shoot, you could be in an office park and have the Xerox isn't working, whatever it is. So it's the goal-directed, I'm going to get the job done, that's what I'm committed to. And obviously it's frustrating, and I think a lot of people, they recognize it's a deviation, but they got through it, and they got the job done here. So I think they just go on. I took care of the job, I got it done, and maybe not always taking the time to say, I should tell somebody about this, because golly, if it's driving me nuts, it's probably driving everybody else nuts, and this is the 10th time this week it's driven me nuts. They'll just be stoic, the classic puritanical upbringings or whatever it is, and go off and get this thing done. So I do think they recognize it, and I do think it can become the new normal, because, they're just going to dispatch the task or the irritant and get on with it.
But you made a great observation, and that's that some people just fix it and move on. So they're one practitioner doing one thing for one patient to make that care's patient better. But they're not necessarily informing people about the opportunity to systematize that improvement. So I think that sets Terry well up for a question.
Well, that was a perfect softball for that question, because I think I agree with that, and I think we have to ask ourselves why. Why don't they? And it's really difficult because from a leadership perspective, you have to ask yourself how people are handled when there's been adverse event with a patient injury, and you look back and there was a workaround that preceded it. And this is the hard thing, and I think that we don't do well in general in healthcare. We have to treat them the same. And I think that if we're going to celebrate people for finding a workaround that helps us do the right thing, we also have to understand that our human beings can't be 100% in the second decision based on everything that they need. So it takes a lot of leadership and culture change to do this well. And I borrow kind of my perspective on this from the resilience engineering literature. And I've mentioned that a couple times already today. I'll tell you, for those of you interested in safety, doing it deeply well, and you're tired of reading articles that start out, in 1999, the ILM, you know, the resilience engineering literature is really great. And what they look at is, in a complex, very safety critical industry, why do all these things go right almost all the time? These things that go badly, we focus in our usual way of doing safety on why they went wrong. We wait for something to go wrong, and then we try to figure out why, and then we do an RCA and fix that one chain of events. The resilience engineering literature says, figure out all the other times it went right. When I go home from the ER some days, I'm like, I can't believe that we didn't have something bad happen today. And you have to think about why. What is it that keeps us safe? And sometimes that why is because we've created an environment to let the people feel safe, to be resilient. But other times, and this gets to Ronnie's question about why don't they do it sometimes, other times we've hardened the culture where people don't feel safe. And I think one of the examples here where the nurse didn't do the workaround, I bet if we kept asking why and talked to that nurse, we'd find out that a colleague of hers who she respected had just been disciplined after an adverse event, and that nurse had violated policy. Because technically, we're faulting the nurse in that case scenario for not violating policy.
I want to emphasize that point. That's really important, that the culture is one that is where people feel okay to share the mistakes that they've made. I got a call, another example where some of the nurses that worked in the labor and delivery area talked to their leader there, their chief nurse, and said, we want to raise our hand and say we made a mistake and we want to tell you about it. We want to figure out how to fix it. What was happening was when the patients came in for delivery, they would bring with them typically a piece of paper that had their labs from external sources and external labs from all around the community, different labs. And sometimes they would be faxed in before the patient showed up. Sometimes the patient would hand deliver them. Sometimes they would come by snail mail. So they would get these pieces of paper in all kinds of different formats that had the lab work from these patients. So the nurses then manually transcribed those lab values into the patient's chart. And she was confessing her sins in that she had put in the patient's wrong blood type. And so I think it was something related to the, I think it was a Rogam injection that needed to be given. And the patient said, aren't I going to get it? And they said, no, your blood type's not the type that needs that. She said, well, yes, it is. And they looked and found out, oh, we transcribed it incorrectly. You know, and so then they put a focus group together and commended the nurses for bringing it forward. And so we worked to see if we couldn't fix it. Well, of course, we could not create interfaces to 50 different external labs, so that, you know, it's still, you know, still an issue, but they put some checks and balances in place to help make it a little more secure, and so that there were, you know, second validation. So culture is important.
I do think that these workarounds are shared, particularly when the outcome is positive, when the result of the workaround is a greater efficiency, when someone has, by sort of using their navigational overhead, you know, finds a better way to do something in the system. They will share that with their colleagues in their training program or with faculty. Ross Capel characterized workarounds in barcode medication administration as falling into three categories: omission of process steps, steps that are carried out of sequence, and then unauthorized steps. And some of these cases represent unauthorized actions, I would say. And I think those are more likely to be covert because of fear of retribution or discipline, particularly if there's an untoward event. If, you know, in the insulin override, an error occurred, you know, that may, no one's going to brag about that, that's for sure.
So it's, if you're successful, you brag, and,
Right.
you know, if you make a mistake, it wasn't my mistake, right? You know, that really does raise, there's sort of consequence for the nurse or the practitioner themselves. and then there's consequence for the patient. And have we really studied workarounds enough to know whether they truly do create a safety hazard? I mean, PJ, you gave an example of, if physicians get frustrated, maybe they'll do a verbal order. And what does that mean? That means it's not in the chart. And that means somebody else could, enter an order for the same medication and you could get overdosed. So, it would seem that there are potential hazards. And how do we create a learning system? Early on today in our first panel and second panel, the concept of a learning system was brought up. And, is there a way for us to create a learning system around workarounds? Because there are treasures, there are gems.
Well, we try to, just to take that example, and you can extrapolate from it, but we try to prohibit verbal orders except in certain circumstances like emergency situations. I would hope we have a culture, I would hope we have a culture wherein a nurse given a verbal order in an inappropriate situation would file a safety report on that, and then we would learn from that, and then we would address it with the physician who's violating policy in that instance.
Yeah, I think a lot of care settings are pretty good at sort of practice innovation. They look at the practice of the specialty or the practice of nursing and absorb, new advances in the practice. They're not always as good as the process, the process of getting this done or that done, et cetera. And I think some of it is just grin and bear it. Sometimes I think it's, it's either fear or perhaps just frustration. Shoot, we've been telling these yahoos in the C-suite this for years and nothing's happened. Or we've been telling our vendor and, they've got, their ears apparently are not attached. So I think, there can be a variety of things, but they're not as equipped as learning organizations on process learning as they are as on the practice learning.
So what percentage would you say of workarounds? So if a clinician is experiencing a workaround, how many times do you think that clinician reports it to anybody? I mean, 5%, 10%, 20%? I don't know the answer to that, but I'm going to guess it's relatively low. And I think that that's a real challenge for us, because the people that can identify the workarounds are the ones that are using the system every single day, day in and day out. So when I was working as the chief of clinical informatics at NIH, the clinical center at NIH, I knew one of my colleagues is here. Laura, are you here? Wave somewhere. So we had, I thought you hadn't left. So we had put together a little icon at the top of the screen in the electronic health record, and it was a suggestion box. And we had a student was here for the summer, and we implemented this suggestion box. Little icon, easy to click on, totally free text. And it allowed the end users to, at the moment of their frustration, click on that and just type whatever they wanted to type. And so it provided a place where they could just, just whine. They could just whine. And it was a great, reading these things were hilarious. And in my mind, I'm thinking that every electronic health record should have the whine button right at the top. And not, how there's this circle with a no whining thing. No, we want them to whine. Because I think that's the only way we're going to get the workarounds out of their brains and into our design. And that's a really hard thing to do. You can't follow them around every day and say, can you think out loud so that I can hear what you're thinking and I can hear the workaround as it's happening? You can't. So we have to figure out ways to do that. And I think that that's an idea that our vendors should adopt, is to put the whine here button and just allow them. And I can share one more thing. We had a student one summer or one semester that was working with me, and I said, can you do an analysis of all the things that have been submitted and tell me how many of them are potential patient safety issues? And it was about a third of them were potential patient safety issues. So we responded to all of them in some way, shape, or form. And I thought, this is something that we need to really push. I don't think most of the vendors have something like that, but it's a thought.
Yeah, I guess the question, it's not just for vendors, it's for healthcare provider organizations. And how do we embed in our systems a communication, a way to share this potential learning, and have the culture such that if it's sharing a failure, that you won't be seen as a failure. You know, that it's okay to fail, you're not a failure, but let us know so we can look at it. So it seems to me to be about culture of safety as well as where providers may be able to partner with vendors to get some learning about this. And I think it would also help the vendor because, you know, you're learning about the processes that have to be worked around.
Yeah, because it's like, you know, you go to a particular retail establishment, you have a bad experience, you're not going back there again. Now, if you could have worked around it, but you really can't, and so you just vote with your feet. You know, or sometimes you get a bad meal and the waitress says, how was your meal? And you say, it was just fine. And you want to say, this thing stunk. But, you know, whatever. I mean, there's probably underreporting as a general statement for all kinds of different reasons. So I suspect part of it is, okay, well, that's a fact. So how is it that we create conditions to get as much as we possibly can, or not rely on the person in the trenches to do the reporting for us? So, for example, can we observe through the system interactions? Like we say, all right, taking you 5 times longer than this other person. Something's wrong here. Or that the barcode, they're deleting social security numbers, or whatever it might happen to be. The other is kind of management by walking around. Geez, talk to me about, you know, what's, you know, driving you folks nuts, and having, you know, sort of taking the time to go solicit ideas and opinions. I mean, vendors have ways. We do, others do. We have councils on safety. We have, you know, come out to, you know, MedStar and walk around, and I'm sure Epic does the same with you guys, and sort of learn this side or the other. So you try to get a variety of things like that. So I suspect the major thing is there a broad organizational program by which input is solicited, above and beyond the sort of culture changes, the reporting changes, et cetera, and realizing that you're going to get imperfect and limited. Frankly, people stepping up, because they said, I got the job done. You know, I did what I needed to do. You know, I got the patient discharged, or whatever, they order in, whatever. So I think there's a broad set of stuff, Ronnie, that's got to get done.
I think that it's a culture change, and we can borrow from, in general safety reporting, what we've learned that encourages reporting, make it easy, right? You know, don't require medical record numbers and all these mandatory fields that have people stop. Just have them be able to click a button and it just sends a screenshot and they can type in or dictate 3 things. You know, the naming factor is a big part of the culture. Workaround is a negative thing. I am not going to report that I did a workaround because that's a negative connotation here. So right here and now I just made up, I'm going to propose, does anyone use the acronym TRA? I think it should become transient resilient adaptation, something like that. Something good, a resilience factor to get people feeling, but the real thing that makes people report is that they see action. No one wants to go through all these mandatory fields to do the right thing and then they never hear anything. So it's action and change, make it easy, and we got to change the culture and the name so that it feels good to do it. I just want to answer one of your earlier questions, Ronnie. I don't think we have the data in healthcare and in EMR, but I think that if you put 1,000 experts in the room around safety, we could say that workarounds make us safer overall, not less safe. I think that's probably would be clear consensus. And I'll make the point of some have probably heard of the method of strikes in factories where the workers come in and decide to do everything exactly according to policy. And it shuts the factory down. And that's true. You can look it up. Does anyone know the name? It's a type of strike. It's like a slowdown strike or policy. But it literally stops the assembly line. So we're in the work as imagined space if we think we're going to be safer if everyone follows our policies.
Well, Patty mentioned that the nursing assessment alone had 597 fields. And I happen to have an experience where my mother, who at the time was 98 years old, was admitted to a hospital on the day that they were implementing their system.
I'm sorry.
And I kid you not, and of course I had interest, you know, I'm thinking, oh, let me see how they handle this. And I watched. It was painful. And, you know, the nurse came into the room and just was trying to go through every field and just said, I'm not going to do this one. No, I'm going to X off that one. And, you know, I was like standing over her shoulder and we were deciding which ones to ignore or not. I mean, that was a workaround. But as Terry said, people are doing workarounds to deliver care faster and better. And if you feel like you need to do a workaround to make the care faster, how do we still encourage a situation where people can take the time to share it more broadly so we can make those changes to the underlying system. I think that's our challenge in terms of culture.
We should just make one quick point. There are some workarounds that are very dangerous, right? So it's not that all workarounds are great and we should model them. You know, there's Emily Patterson wrote a paper about a workaround at nursing homes they observed where they just, to save time on the barcode, they just lined up all the dishes and put the meds in by room number just by memory. That was not safer. We just discovered in our own system a physician that's not comfortable with the EMR, so they're typing their notes and emailing it to their assistant who's putting it in the medical record. And we found that their assistants didn't have the authorization to save it, so all these notes are lost. So some workarounds need training. That one needs training, right? And some aren't safe. So I think, though, as a whole, we need to embrace workarounds and make it safe for people to tell us about them, because I think workarounds are going to help us identify how to get better.
So I think that in addition to a more positive name, which, by the way, needs to spell something. So we can work on that during lunch, we can work on that. I'm also thinking, as you're talking, that there's a workaround continuum, you know? There's the 0 to 10, the 0 are bad, the 10 are really good. And that, there needs to be some kind of rating scale that organizations use as part of their ongoing evaluation. We identified 5 workarounds this month, or 5 TRAs, whatever we're going to call them, this month. Let's look at them, and where do they fall on this scale, and which ones do we need to allocate resources to dive into and see if we can make those improvements. Something else we can conceive here.
I'm just going to make one point, and then we're going to move to question and answer. One thing we really didn't touch on is that we implement a lot of blocks in the EHR in order to encourage safety. It's put in there intentionally to force people to stop, to pay attention, to hear an alert if the alert goes off. And yet, I think that those very safety blocks are some of the biggest workaround issues. So just food for thought for everyone. Another thing to study.
Ronnie, I related this anecdote earlier. When we implemented our previous inpatient EMR, Brian Strom was then at Penn, and Brian proposed a randomized clinical trial of alerts with some patients, and I forget exactly how we were planning on doing it, but some patients, alerts firing on some patients and not firing on other patients. And there was a great hue and cry about that, because the presumption was that the alerts must be safer. And the reality was we didn't know. And at the end of the day, we ended up with relatively few alerts that we built into the system, in part as a result of that.
Okay, so we have people on both sides, and let's start on this side, and if you would please state your name and ask your question or make your comment.
I don't know how to get it live. There it is. Okay. Michael Harrison from HRQ. Thanks, folks, for a very exciting panel, and thanks for an exciting conference. Could you consider for a moment the role in learning about the interaction between IT and clinical processes, the role of IT support? And I want to just suggest that the way IT support is typically structured is to solve the problem of the individual user. And I'm wondering whether there couldn't be a learning loop that both provider organizations and perhaps even vendors could use, okay, to learn about what the problems are that the user is actually encountering.
So that's a great point. So now I'm working at Vanderbilt. We just went live November 2nd with Epic, and I'm seeing exactly the phenomenon you're talking about. So a user will call and is struggling with something, and the IT support person wants to fix it for that one person and not thinking about the bigger picture. I'm seeing that. And so I think that organizations need to put in place methodologies so that there's a collection of these issues, so that there's nothing put into the production system without some kind of a vetting, without some kind of a review of whether or not this is an issue that's impacting everybody or is it just this one user. I think that's really important. And I think that that's something maybe we don't stress enough, because you have a renegade IT builder who can just configure that change just like that in production, and it's there. And then, I think that we need to address that.
Yeah, I mean, I think, and I can't speak for all vendors, but you have formal support, which is usually the 1-800 I'm stuck, and, to get you unstuck, et cetera. Usually the leadership of those groups steps back and says, all right, we had 100 calls this week, what are they all about? And so is there a pattern going on here? And there's other conversations, and there are conversations where you sit down with the leadership of the organization and say, golly, we're really having a hard time with this process. How do we make it better? And so there's a bit of a different altitude. We send people, as do others, to discussions about, golly, we got to do something about the copy-paste thing, because it's bad. But what do you do? And what are some of the issues? So anyway, there's a range in which there's this sort of, the systems are in play. There's a way to make them better, or they're causing trouble, or the value isn't what we thought it would be, and how do we sort of get where we would collectively like to go? One of which is the 1-800 I'm stuck. So anyway, I think there is in most places a broader array of efforts to sort of understand how to make these things function a little bit better.
I think this is something the vendors do much better than we as providers, and I think that just like sometimes PSO data isn't trended enough in some organizations and it sits there until the adverse event occurs, I think our individual healthcare provider, hospital-based IT help desk is doing the individual calls and not trending it. And that's one thing. We're in the early stages in our system of actually doing qualitative analyses, trying to see if there's trends that we can identify. And in the future, we'll all be using NLP to do that in a more automated way.
Right. This is a little bit off topic, but I think generalizable. In the area of physician behavior and professionalism, I encourage our chairs and program directors to pay close attention to complaints from people at the front line, particularly trainees, about more senior physicians and their performance and their behavior, because they oftentimes, without calling it as such, recognize cognitive issues and physical disabilities that are impeding or impairing performance. I think similarly, and I agree with Terry's point here, that provider organizations don't do a great job of culling that sort of information from the people at the front line who are hearing those complaints at the IT help desk.
Yeah. And we've had a similar situation. We've actually had some provider organizations give us their help desk logs so that we can help to sift through them. But I think NLP is going to be a solution for that. It's very difficult work, very challenging. Why don't we do this side?
Okay, Ann Irving, Premier. 2 quick points. The panel was asking, what is the percentage of adverse events that actually occur for which there's a report made? And there have been studies on this. I can't quote the author, but in one case, I come from the risk management field, there are 20 events of the same type for which 1 report comes in. So it's grossly underreported. And I would say from my clients that the concept of including a workaround or some glitch or whatever with the EMR isn't even on the people's radar screen to make a report, okay? Mm-hmm. Now I want to ask Patricia, because you had me really worried, my heart was going fast. When you said that your EMR has a button to report, okay? Mm-hmm. From a risk management point of view, if it's a totally, just happens to be their button that links to your online event reporting process, I'm thrilled. But if it's a part of your EMR, there is a risk of legal discovery, okay? Because it's mixing a legal health record with a quality risk reporting system. So I don't know if you wish to get into the details or not.
No, we can talk offline, but it was purely a suggestion box with a lot of disclaimers on it. So, yeah. Thank you. Okay, sure, thank you.
Okay, let's go back to this side.
Hi, my name's Hannah Jackson. I am a primary care provider here as well as a health policy fellow at Georgetown. So I trained at Yale, where similar to Penn, we were connected to a large sort of network of other providers within the same EHR, and the connectivity was extremely powerful and something that I don't know that we had before EHR. So I could communicate with specialists easily. I could see results of labs that I hadn't ordered, et cetera. My concern is that the majority of primary care is happening outside of academic centers who don't have sort of the same buying power. And so we're using EHRs that are less effective and efficient, and most importantly, aren't connected to these other hospitals or systems. And so getting information about what happens to my patients outside of my care is a monumental task. And then similarly, patients have an expectation now that we can see everything because it's on the computer. So the number of times in a day that a patient tells me to just look at the computer as if that holds all the answers, I can't even count. They don't, and then when I try to explain to them I can't see what Lasix dose they were prescribed by their cardiologist, they get angry because, again, there's this expectation that now we should all have this information. And then finally, sort of from the payer side of things, if I have a patient who had labs drawn somewhere else yesterday and they come into me with complaints that are concerning enough that I need to know those results, I will reorder those labs and get the lab tests done now twice within 48 hours, which is just extraneous sort of extra cost. So my question, after all of that, is who, if anyone, is sort of responsible for improving the connectivity for the majority of us providers using EHRs outside of sort of academic medicine?
Terry would say.
Well, I think we all are, and I think if you look at it closely, you see barriers put up by every, there are barriers and breaking down and putting up barriers in every component of all the connect points that have to be there to do it well. Sometimes it's a local government barrier, sometimes it's a HIPAA barrier, sometimes it's vendor barrier.
It's a financial barrier. There are
Yeah,
financial barriers. Yeah.
So it is complex.
Yeah, I think when you look across industries of where did an industry come together to collaborate to create an infrastructure that is shared by all, and you could look at universal product codes, you look at the SWIFT network that banks use to settle up at the end of the day. Those happen when the industry felt it's in our individual interest for this to happen. And I'm not sure we're quite there, to be blunt about it, in healthcare. Where you do see a lot of it now is, and this goes back to our initial panel, is where the risk arrangements are starting to put people on the hook for being accountable for the care of a cohort of folks. And all of a sudden they say, golly, if I want to characterize John Glasser, for example, I need data from all these different EHRs. I need his claims. I need his social determinants. I probably need his genetic stuff. I need some device stuff, et cetera. All of a sudden there's real motive to starting to pull all this together and to deal with the inconsistencies and the crap that's in the data. So to the degree who's driving it, it's largely organizations that say, I'm accountable. But it could be an employer, and it could be Medicaid, for example. And that's where a lot of this, and it parallels and is complementary to health systems trying to integrate for a bunch of different reasons, and regional or statewide HIEs that are going on. So it's kind of this patchwork of activity going on in the U.S., but where it really happens is when the motives are really, really strong to make this kind of stuff happen. I think we're, per the first panel, we're getting there, but I don't know if we're quite there to drive it broadly, above and beyond the complexity of the whole darn thing.
In one circumstance in our health system, one of our hospitals made their EMR available to anyone in the community who wanted it. They were outside of Philadelphia, and they were the dominant player in that market, and it created some brand loyalty by, bringing primary care physicians into the network. In a place like Philadelphia, with 4 or 5 academic medical centers, there is a financial issue that gets in the way of doing that. Although we're thinking about it right now, but it's to your point about reordering labs, if you can keep people in the same system, in the same healthcare system, there's evidence that you can hold down the total cost of care by, having evidence or information available across the entire system.
And you talk about your mom. When my dad was having a lot of health issues and was seeing a lot of different specialists, I had his health record as a proxy. I would get all of his data, and being the nurse in the family, I would help him navigate things. And I put everything on a flash drive, and he carried it with him everywhere. I mean, I know that is so not ideal. And where's that risk person? She's probably groaning now. But,
Yeah, if we put it in our computers, it would be encrypted immediately.
Right. It's complex. It really is.
Let's go to this side.
Sure. So I'll start by saying my wife is an anesthesiologist and a certified Epic builder. And there are good installs and good maintenance, and there are bad installs and maintenance. So the question for the panel is, are some of these issues underinvestment by facilities to maintain and install their systems? And the fact that these systems are so flexible and customizable, is that a good thing or a bad thing?
I think Net, it's a good thing, although sometimes I think people overdo the sort of uniqueness that they think they possess here. What's interesting is if you go back over IT use by a range of industries over the last 50 years, so this is financial services, transportation, the whole 9 yards, and you say when organizations are very effective at applying IT, why are they very effective? What makes them very effective? And there's really 3 factors at the end of the day. One is obviously they have leadership and talent that works well together. How about that? That's probably true for any organizational undertaking. The second is they had very good governance. They could make decisions, make those decisions stick, and have them in a reasonably transparent process. They didn't go round and round in circles for forever, or make a decision and have that crumble the first time someone said, I object. A 19-to-1 vote is a tie. They didn't have any of that kind of stuff going on here. The third thing they had is they were very good at managing change. They knew how to do that. Year in and year out, depending on the topic, they know how to manage change. So I think what you have is in a lot of organizations, and vendors can mess it up too, although it's striking to me, you can have brilliant CERN implementations and fiascos, same darn technology. It's those 3 factors. And sometimes I think, and we try to get better at it, is this sort of look in the eyes of the leadership team and says, you're not ready. Whatever, your decision-making structure is too convoluted, you guys are, you're not competent at managing changes. But anyway, I think those are the big, turns out those are the big 3 that at the end of the day determine success versus not.
I want to really echo that and agree with John and then twist it by blaming the vendor for this a little bit. Because I think that we've let the market drive this too much, and John's right. The health providers out there, we all think we're special. Everybody's different. And the vendors allowed us to do that too much. And I think my voice, my opinion that I think we should further is vendors have to become more paternalistic. They have to put more people with gray hair from their organization in the implementation. And not the implementation people that are doing it for the first or second time, but people who have experienced a lot and can pass on the learnings from the other organizations.
Hello. I want to switch gears a little bit. All of our panels this morning, without fail, expressed frustration around being able to access data from the electronic health record for quality measurement, quality improvement, population health management. And I'd love to hear from some of the panelists around, well, what I remember in the early days when we were advocating for health IT, this was one of the big drivers. And it sounds like it's not working very well. So what needs to be done? Does Congress need to do something? Does the administration need to do something? Or is it something that the private sector? It feels like this is a big problem that should be solved.
I think there's a couple of attack vectors, Janet, one of which goes back to comments made at this thing, is actually reduce the amount of data to be collected. Because one way you get crappy data is you overwhelm people, and they just shortchange it, in the process of just getting through the day. So that's sort of one. The second, and I think we've hit the wall on this, is asking the caregivers to collect more in a structured way. And it's no mas, we're done already. The third is I think there's a growing array of fairly novel and sophisticated analytic techniques where you can use machine learning and other types of things to fix the data or correct it. So, when I look at population health, we bring in data from all kinds of different places. Machine learning says, listen, there's all kinds of crap here, but this is what's going on, and sort of resolve stuff. So there's this blend of I think, just easing up on some of this stuff, maybe a little bit more, maybe we get the patient to do more. I mean, it's the classic, the airline's making you do more, and sort of moving stuff around, and then I do think a lot of it is on these novel techniques. But again, I doubt it'll be the same rigor that you might see in a Scandinavian registry, at this point.
I think the glass is half full. I think that we are getting a lot more information. I mean, we're seeing it in outcome measures. We're seeing it in risk adjustment tools. We just have a lot more information available. It's not perfect. There's certainly more that can be done. The free text issues, show that we underperform, and when in reality we've done the work, we just don't have it in the right box. But I think I think the glass is half full.
I do too, and I think what I'm seeing is that some of the tools that are now available to aggregate the data and trend and manipulate the data are becoming a little more user-friendly. There was a time when you had to know how to program and do all kinds of, manipulations behind the scenes, but let's get the data into the hands of the people who maybe are using it every day, that can answer questions, that can help their practices. But the data needs to be in a format and in a tool that they can do that with. I know some of the systems I've been working with, they're really trying hard to do that. And so, and then, putting things into tools like Tableau, so that you can actually move the data around and do something with it. So I'm starting to see a little bit easier methodologies to access and manipulate. So I think, we've got a long way to go, no doubt. But I'm starting to see a little bit of improvement.
I'll just echo that. I think that we are much further ahead. We've got a long way to go. I personally, actually now that we've had full implementation and not halfway, my job seeing patients is easier now. Now, and our vendor is married to a really good dictation service, and I think without that marriage, it probably wouldn't be. But I also can look up patients' histories in competing hospitals because we have a good network. So I think we have a long way to go. But I think we've all said it's half full, and we're getting there. We're just in a painful moment.
Yeah, I think that the challenges are pulling together data from disparate sources. So, you've got the electronic health record with very rich clinical data, but you want to marry that along with claims data, patient satisfaction data, all kinds of population health data, and I think that's where most organizations are still struggling, trying to figure out what's the best way to pull all that together in some kind of a data warehouse, and then allow people to then go and ask the right questions to answer, what their needs are. So, more to come on that.
So I'm getting the signal that it's time to wrap up,
Yeah.
but let me ask each of our panelists, and this is a surprise question.
Uh-oh.
So if you could just say this in maybe 3 words or less, where do you think we're going to be in 2025 with this issue?
Will be optimized.
I think this panel will still be relevant.
I think so.
I think it will be much better, but I think that also in 2025 is far enough away. There's probably problems and solutions that we haven't envisioned yet. And I think that visualization, video and photos in the medical record substituting for text will be probably a large part of what we're doing then.
Mm-hmm. Yeah, I keep thinking that the nurse should be wearing a body camera, and that there'll be,
There are people trying that.
yeah.
It's funny, I just got an alert saying that I actually said that in a meeting that I can't remember saying it at. Well, thank you all for being here, and a big thank you to our panelists who have done an outstanding job.